We have a special guest today. Cynthia Price is here. She's my mentor for MABT, which she'll tell you more about. Back in the day, had a professor who told me that I should fly out to Seattle and do the training in MABT and bring it to Iowa. And I was just like this little, like small version of myself, like a little boy, was just like, oh, that's too much for this little kid to do. And but I did it. And here we are today. And not only launching it in Iowa, but we're sharing it with S4OM. So I'm proud and pleased to be able to invite Cynthia here to talk a little more about it. One of the reasons that I thought it was important to the work that I do is because, so I work in a hospital, I work at the Richard Deming Cancer Center, and then I have a private practice as a provider for the VA. So I see war veterans and cancer patients. I'm also a psychotherapist, but with a focus on trauma and dissociative disorders. MABT has been the single most important technique and intervention that I've used for both touch and talk therapy, especially for people with depression and anxiety. And as I work in the cancer world, I see a lot of depression and anxiety. And we're all familiar with lymphatic drainage and scar tissue remediation and other kinds of advanced trainings, and obviously foundational oncology massage training. But when I first joined S4OM, I was noticing there wasn't a lot of, for lack of a better concept, psychotherapeutic support, trauma-informed care, body-oriented trauma-informed care. And so I had a vision to hopefully one day spark some conversations about this kind of work. And I strongly believe that MABT is the modality for massage therapists for many reasons, but from clinical reasons that I've observed myself. Uh, it's not going to take 3.5 years in a graduate school investment to go through the training, but it's just such a beautiful and elegant model for body-oriented therapy. It's a pretty informal conversation for today. Well, Cynthia, if you're ready.
So, hello, everybody. I'm Cynthia Price. I live in Seattle, Washington. A little bit about me. I was in private practice as a massage therapist for 20 years, mostly in the Boston area, and then moved to Seattle in the end of 1999 to do a PhD at the University of Washington School of Nursing to do research related to touch therapies for what I thought it was going to be, what I was going to do was trauma related recovery, because that had been how my practice had sort of unfolded over the years. So for the last 25 years, I've been at the University of Washington doing research, NIH-funded. I was very, very lucky to kind of start my career as a researcher right when NIH started putting out funding opportunities for massage therapy research and other kind of related things. And so anyway, and then around 2016, I started a nonprofit to find ways to teach what I had developed as an approach for helping people bring attention to their bodies. And I'll talk about that in a minute. So, every once in a while, and this is what Marcus attended, I would teach a program in the community for body workers and psychotherapists and people in other disciplines to learn this work. So I'm still doing that. And that's kind of more my main focus now. So the work that I developed is called Mindful Awareness and Body Oriented Therapy, or MABT. And it's really focused on helping people learn to bring attention to the sensory awareness on the inside of their bodies. And so that's kind of got a strong mindfulness related overlap, because we're focused on helping people develop a lot of presence and attention to their experience on the inside of their bodies, both on the physical level and an emotional level. And those work grew out of my work with people who had had really intensive interpersonal trauma histories when I was in private practice. And they were so disconnected from their bodies. And it was like, how do I help them learn to get more connected with their bodies? So that's sort of the background of sort of how I got started in this. And I had studied focusing. I don't know if people are familiar with that, but that's Eugene Genlin's work that's focused on the felt sense and is more about kind of toggling back and forth between attention to a somatic experience of emotion in the body and then talking about it. And then I took that concept and kind of deepened it for really developing capacity for sustained awareness in the body in this mindfulness facilitated way. And what I really was focused on was how can people learn more of these skills for their own self-care that they can bring into their daily lives, integrate into their daily lives, so they have more emotional awareness, more capacity for self-regulation, which is so basic, key element for health and healing for people who are living with distress. So anyway, that's really the kinds of things I've been looking at as a researcher is, do people learn these skills? Do we see a reduction in mental health distress? Do we see an increase in capacity for emotion regulation? And so I've been looking at those kind of outcomes over the last 25 years in my research, and we do see those things. So one of the reasons that I'm here to talk to you today, too, I think Marcus and some others have invited me to speak at the upcoming conference in April about this work in more detail and its implications for cancer care. So I'm not going to talk about what I'm going to talk about there exactly, right? Because I'll have more time. But interesting time-wise is I just got invited to work on my first oncology study for this year. And so, because that hasn't been my area of population focus, I've been mostly working with people who have had substance use disorders, lots of trauma, a lot of chronic pain. And honestly, I think this type of work is pretty applicable regardless of sort of what your mental or physical health condition is. It's really about helping people gain more skills for self-care and emotion regulation. And that is helpful to all of us and applies across all these different kinds of conditions. One of the things that I think is really helpful to know is that people who have a lot of physical and mental health distress tend to not process sensory information in the body very well. And we see that in neuroimaging studies, and it's been very well documented for people with chronic pain, high levels of stress, mental health disorders. And now there's some kind of scoping reviews coming out in oncology that shows similar patterns. And so what this basically does from sort of a physiological perspective is support the concept that this is an area that really has some physiological evidence behind it, that we need to help people have more capacity for attending to their bodily experiences for emotion regulation. And we know from the work I've been doing that you can really teach this work and people can learn it, and it develops more plasticity in the brain so that folks can really pay attention in a better way and help themselves. So that's sort of been my work for the last 25 years. Well, actually 40 years, but from the research realm, 25 years. And yeah, so I'm excited to kind of make a new inroad into the oncology world and to bring some of this to all of you. So I'll pause for a minute and just see if there's any specific questions people have. That was just kind of a quick overview. You're muted.
Is this in any way similar to somatic awareness and trauma-informed care? I mean, is what you're doing kind of a similar field?
Well, it's all about somatic awareness, and it's specific to helping people become more embodied, to bring that awareness into their internal experience of themselves so that they're just more aware of how they're feeling on all levels. But also with this work of mindfully attending to bodily experience and learning to sustain attention in certain ways, people have the experience, and Marcus, you feel free to jump in if you want to talk about this, but people really have the experience of over time, sometimes immediately, sometimes over time, feeling really more connected to their bodies, really more having their body be a part of who they are and how they understand as their body as a positive resource versus something that they want to disconnect from because it's painful or it's distressed. And so that's a huge shift for people. And I think this work is really teaching people the fundamental skills in order to kind of have those kinds of experiences. So I hope that helps answer your question. Anything you would add, Marcus?
Yeah, I would just add that there is a sort of implicit in the co-regulation and the touch work, bringing attention into the area that's being worked, provides implicit messaging that it is safe to be in a body. And this is something that, at least at the clinic where I work, many of my clients are just so grateful to have the opportunity to feel welcomed back into their body, especially in a situation where they're going from clinic to clinic, receiving infusions or radiation or chemotherapy, or sometimes working with social workers who may not have the kind of perspective that we have as body workers to provide space for the clients to downregulate their nervous systems. And I get the feedback from my patients who often will say pretty profound things like, this is the only appointment of the week that I look forward to. Or, you're the coolest person I've ever met. Things that really bring joy to their life. And this is a vision that Dr. Deming, I'm not as joyful as Dr. Deming, but he'll come in and I'll be like, "Good morning, Dr. Deming. How are you?" And he's like, "Great." And I'm just like, that's way too much emotion for 8 a.m. And or he'll go into an consult and he'll ask them, "What brings joy to your life?" And he really helped me to see the importance of that psychological support for the patients. And MABT is one of those interventions, as is massage therapy in general, but to support clients in a way that provides implicit appreciation for their body as opposed to dissociating from the surgical wounds and thoughts around scars and such.
Any other thanks? That was great. Addition, anybody else have other kind of questions or thoughts on the top of their head? If you want
I just want to say hi. I haven't been in a while, and I just joined AMA. I'm in California. Nice to see you all.
Welcome. Good to
Thank
see you
you.
too. Cynthia, do you want to talk a little bit about the way MABT helps clients long term?
Yeah. So with the research that we've done, where we sort of longitudinally followed people, it's most research interventions NIH doesn't really want to fund more than maybe 8 weeks and maybe 12, so you just are beginning the process of helping people learn these skills a lot of the time, because our research has been primarily with people for whom this type of work is very unfamiliar. But then we follow people for 9 or 12 months out. So they have this 8-week intervention, and then we keep every 3 months or so meeting with them and gathering information about various outcomes. And we have seen, kind of depending on the population, it's varied, but in general, we see continued capacity for interoceptive awareness and people using the skills that they've learned many, many, many times a week, a year out after the even just 8 weeks of this approach, which when I first saw that, I was kind of shocked. It's like, what's motivating people? And we did, focus group. That was a long, long time ago, one of the first NIH studies that I was funded on. And we asked them, why are you, what's motivating this high level of continued use of these skills? And what they said was, we didn't know how to we didn't know how to manage our emotions before. And these were folks who were in treatment for substance use disorder, high levels of PTSD. And, the coping skill for when the stress went up was to exit, just like, I'm cut off from the head down and I don't know how I feel. And I'm either going to use a substance or I'm just going to do whatever, but I'm not going to pay attention to how I feel. So that has been a consistent across all of our studies, kind of over and over again, that kind of messaging for, oh my gosh, I did not know how to pay attention to how I feel, to provide myself the space to pay attention, to be with it and let myself just feel those feelings instead of feeling like I have to push them away, to accept myself and my feelings. And then even further than that is knowing how, which we teach in this approach, to take the time to kind of, on a mindful kind of attention level with oneself, take the time to let things kind of move. So that shift that can happen when we're really with ourselves in a loving way, right? So that something isn't so, the feeling isn't so intense, or we make assumptions and we as we understand it better, and we can kind of have what we call somatic reappraisal processes where it's very therapeutic. You're not caught in the same sort of traps of rumination and so on and so forth that go so frequently with depression and anxiety. So people really, every single study we have where we collect longitudinal data, this is what we see, which is super exciting, because it means that in a relatively short time, people are learning skills that they really practice and they bring into their life. So that's one of our outcomes. We've seen less substance use, lower depression, lower anxiety, higher level of emotion regulation, less pain, chronic pain, those kinds of outcomes as well. And sometimes they are stronger, improvements immediately after the intervention, and then they aren't always continued long-term, but a lot of times they are continued long-term. And I think that's because people are practicing these skills consistently. So that's a little bit about the research. I think what I'd like to kind of hop onto with what Marcus said earlier is so much of what we're helping practitioners learn is how to be present in themselves and present with their client, and then facilitate presence in the client for the client, right? Like it's all happening all at the same time. So when Marcus talks about co-regulation, that's what that is, right? It's like we've got our hands on somebody and they're feeling that. And if we can be in presence as a practitioner and help them be in presence, then we're co-regulating between them. And that creates a whole new thing going on. And this is something that, I think as body workers, a lot of us are aware of, right? Not something that we have studied in this field very much at all, but it's such a wonderful tool, and touch is such a wonderful tool for helping somebody be present in their bodies and helping someone to bring attention to a very specific region of their body. And that is what we're focused on in this approach, is how to help someone follow where the hands are and come down into that place where the hands are on the body and really be deeply present in themselves. So that's this work in a nutshell. Yeah. Any more questions about that?
I'm not sure this is really a question, but I was on a call earlier today that talked about mirror neurons and using, it was for like CBT with parents with children who are having challenges. So it's trying to train the parents, right, to how can you help your kid get calm? Well, find what's triggering you, take some space, and then approach your child from a place of calm. And that will be the first step towards helping them get calm because that mirrors like a transference, like you were talking about.
Yeah, yeah, no, totally see why you thought of that one. Yeah, very similar process. Yeah, yeah. Anything else?
Cynthia, what is this idea of interoception?
So interoception is awareness. I mean, the definition is awareness of internal body sensations. And it's a word that really wasn't used in clinical care until maybe 10 years ago, 15 years ago, max. And so I've been very involved in sort of those of us who are doing clinical research in this realm of body awareness and body awareness internally, on sort of writing about this and developing scales for measurement for those of us who are doing this type of work. So there, you know, we've from a definition perspective sort of broadened the understanding of what interoceptive awareness is from simply the kinds of things that used to be talked about, like I feel hungry, I feel cold, I feel tired, these kinds of processes that are totally related to homeostasis and staying sort of balanced in our internal systems, to kind of broadening that to include other kinds of awareness in the body that goes into physical sensation and emotional sensation as well. So the scales that I've helped develop address that. So the most commonly used one is called the multidimensional scale of interoceptive awareness, or the Maya. And so we use that a lot in research. It's being used all over the world for research where this type of thing is being addressed. So when we talk about interoceptive awareness, it's body awareness in a global sense, but that's a nice overall word, and it works for most people. You know what body awareness means. It's just about awareness of internal sensations or internal spaces in the body versus proprioception, which is awareness of our sense of movement in space. So that's my long response to your question, Marcus.
I do appreciate it. Interoception is a word that's becoming popular. It's also a word that's being used to facilitate new forms of therapy and I'm noticing non-clinical applications of it being published in the Amazon world of book publication. One of the reasons, this is going back to when I first met Cynthia, but one of the reasons that I decided to work with you is because I was on the USABP. It was a conference call with therapists from around the world, and I call it speed dating for therapists and certifications. And so, like Gabor Mate and others were presenting their work, and essentially it was kind of an opportunity to try to promote students and other therapists to get extra certifications. And I was so excited. I was just like, oh my gosh, there's people on this Zoom call that are like legends. And at the time, I hadn't heard of Cynthia, and she comes on and she starts talking, and I'm just like bowled over because everybody else is more like a salesman, and Cynthia is a clinician. I'm like, oh my gosh, there's actually a professor here. and and once I started diving into her work and seeing the intellectual richness and the support that the evidence and the research has been providing, I knew right then and there that I had to sign up. So that was really exciting, and I'm very proud to be a MABT certified clinician. Um, the assessment tools that you have are wonderful, and they complement the work and the assessment tools I use in psychotherapy. I don't know if you know this or not, but I did a little dive into the history of interoception, and it goes all the way back to a neuroanatomist named Charles Sherrington, and maybe even prior to him. But that's one of the earliest citations of the word that I've been able to find. And so I'm always looking for anyone that has a legacy or a historical foundation that stretches across time through the academic and research oriented spaces. And so I was really kind of impressed by that as well. And also, Cynthia is one of the only social scientists that's being funded by NIH. And NIH has presently expanded interoceptive research globally or nationally, I guess, to research scientists who are working in specific organ systems. And so there's lots of funding for studying interoception in vivo around the heart, for example, or the liver, and so these research teams are focusing only on single organs to do that. There's millions and millions of dollars being pumped into this. And so it's super exciting on that level for me to work with one of the only social scientists that are funded in the same work. So I suspect that we're going to see a lot more coming down the pipeline as this information from the researchers comes to light.
Yeah, it's been an interesting thing to see how this is unfolded, because it's really the mindfulness-based research that made interoception even come onto the radar of clinicians who are doing research like myself, because they were wondering, well, why does mindfulness work? Like, what explains it? And so that's how the neuroimaging studies started, where they looked at these sensory pathways to the brain and that had already been identified by an anatomist, where those areas of the brain were that were associated with regulation and the sensory processing system of interoception. And so it was these mindfulness researchers who went, oh my God, this is what's happening in mindfulness. It's going to these same places. And without them, we would not be where we are right now, with this kind of area of research being so like zing, 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 zing. I mean, it's stayed very focused in brain sciences, and now it's kind of going, as Marcus mentioned, into some more medical, biological realms in ways that it hadn't. And there's still a lot of room for more. But anyway, yeah, my work is really about how do we teach this work to people for whom it's, we want folks to have more skills for their own awareness and well-being, right? And that's what I care about. And I know we can do that. I've done enough of this now that we've got that very clearly shown that we can and that it matters. So yeah. Any other questions people have?
Yes. Happy New Year, everybody. This is
Happy New Year.
Donna. My question is, are there any studies that are comparative studies, for instance, studying interoception in one medical population versus an oncology population? And if so, what research stands out for you?
You mean looking at interoceptive awareness for people
in oncology patients versus another population?
Yeah.
I mean, maybe heart patients, cardiology patients, I don't know. Are there any studies?
As far as I know, not. There's been very little research looking at interoception in oncology in general. I mean, just very little.
Donna, that's such a great idea.
I would love to know, to
yeah, I mean I just did a recent kind of look at a review of the literature, partly because of this new project I'm going to be on with oncology patients, and there's really, from what I can tell, there's really been nobody who's really looked at interoceptive awareness, like teaching people things.
Yeah.
I mean, you could have some mindfulness research that's been with oncology patients, but if they haven't studied and measured interoception, you really can't. They overlap, but I don't think it's been measured. So, or if it has, I didn't see anything. The only thing I can say, and I said this maybe earlier, I don't know if you were on the call, is that from a neuroscience perspective, there has been a review of neuroscience imaging studies with cancer patients across multiple years, and it shows that the areas of where there's impairment of processing sensory information appears to be consistent in cancer patients, just like it is for people who have chronic pain, depression, anxiety, PTSD. So that suggests that, as you would expect, because it's really not about the condition, it's about distress. It's about living with distress and how we manage distress. That's across the board. It doesn't matter whether it's cancer or diabetes or mental health or substance use, or it doesn't matter. People who are managing a lot of distress really often disconnect from their bodies and are not processing sensory information. And I think that's pretty consistently acknowledged at this point in terms of the evidence of what we have from these neuro imaging studies, and cancer patients fall into the same category. So that is the main thing I saw in the literature that was anything that kind of relates to your question.
Okay, but nothing thus far in terms of teaching.
Not that I've seen.
How to, okay.
Not that I've seen. And that doesn't mean that I might have missed it, but not that I've seen. Yeah.
So let's get busy, S4OM. We need to do some research.
That's the goal.
Thank you. Thank you, by the way, Cynthia.
You're welcome.
Thank you for that.
I love your idea, Donna. Lead the way.
Okay.
I wonder if
One of
it's appropriate to mention a book from one of our previous summit presenters that's on this topic of mindfulness. Is that okay for me to
Sure.
bring up?
Go for it.
I don't know if you guys sat in at the in-person summit a couple years ago to Pawan Barija's talk. She was working with trauma and mindfulness. She just published a book December 1st.
Pull it back a little, Amma. Pull it back a little.
Reignite your power, right?
So she's a breast cancer survivor herself, and she's a somatic experiencing practitioner and teaches mindfulness internationally, nationally, and she's in Arizona now, and she comes to California a lot to teach at Spirit Rock Meditation Center with Jack Kornfield. She just put out this book, Resolving Trauma Through Mindfulness, and that's her modality, is using and guiding her clients, patients, people going through PTSD or anything overwhelming, and she's using mindfulness practices, and the book is full of them. So you read a bit, learn a bit, and then there's a practice. Read a bit, learn a bit, there's a practice. So it's really well paced for a nervous system to take in the information. So it's a delight. I'm like a third of the way through it only, but I just wanted to mention it because she was one of our teachers.
Very cool.
Yeah.
I just finished my somatic experiencing training in Kansas City with Joshua Silve, and one of the things that I thought was interesting to me so I have dual licensure as a LMT and a LMHC, and a few of us have those credentials, and we were noticing the psychotherapists were all freaking out, and then a few of the massage therapists were freaking out for different reasons. But Joshua's approach to pedagogy is very, very quiet. And so when he's performing a somatic touch session, it's a lot of silence. And so everybody's just like, oh my God, what do I do? What do I do? What do I do? And it occurred to me as I was working with my volunteers that my MABT training was what actually allowed me to excel in that block of somatic training. And with somatic experiencing, it's a wonderful, rich canvas of interventions that we're trained in. But I have to say that in my experience, the MABT training was actually far richer in its the way it was developed. And we have an internship that we go through that's 8 weeks long. And we have 2 clients that we do case studies specifically with, recording everything, and then experiencing individual consultation with a educator within the nonprofit. So I actually used my knowledge in MABT training to help other students to better understand what Joshua was doing. And the one thing I emphasized for them was, first of all, turn off your brain and get into your body and sense your body, noticing the sensations moving through your shoulders, your breath down into your hands, your torso, your sits bones, and your legs and your feet on the floor. Because it's your awareness that's going to allow you to downregulate to a place of presence where you can then begin to consider beginning the session. And when you arrive in your body and you feel a little settling, that's when you can invite the client, is it okay if I place my hands on your shoulders? And they say, yes. And you gently place them on, sensing, noticing, and being with that person. And that's when you start to see the micro movements of the body, and their nervous system is actually coming into co-regulation with you, and they're down regulating, and then softening starts to occur. And for me personally, what I like to do in that situation is invite them to share with me what they're noticing. Instead of me saying something like, hey, I noticed that your shoulders just moved, I'll say something like, what are you experiencing right now? And they'll start to come out with all this information. And it's a little bit of a difference from the protocol for MABT, but it's MABT influenced, heavily MABT influenced. And 9 times out of 10, the receiver of an event like that is going to be like, oh my God, thank you so much. This is one of the reasons that this is so important to me, not just in oncology, but in life, in modern living, is that we've been kind of robbed of our connection to community with one another. And MABT can bring us back into our awareness through attention and intention, through co-regulation, to rewild our nervous systems back to what it was before we became put into this kind of capitalistic system of widgets and numbers and dollars and objectification of human experience, and really in many ways oppression. And so this can bring us back into our ancient experience of what it is to be a human together with other humans.
So when he was being really silent, he just wasn't explaining his process? Is that what was going on, Marcus, that you were helping with? I'm just curious about that.
Yeah.
Yeah.
Yeah, he wasn't explaining his process.
Yeah.
And it was driving everyone insane. And I was just,
They're like, what's going on? Yeah.
yeah, because he was standing on the stage. The massage table was in front of him. The client was on the table, and he's behind the client, and he's touching in spots, but we can't see where he's touching.
Mhm.
And the silence was just killing everybody.
Yeah. No, I know. No, yeah, it's like a black box otherwise, right?
It is,
Yeah.
but the thing that I love about Joshua's approach is that it's his approach,
Mhm.
and as he really promotes everyone to find their own kind of flavor of the therapy,
Mhm. Yeah.
which is actually MABT. Carla was telling me the same thing. We do the same thing with MABT. Is I was going through based on I'm a big people pleaser. My trauma response is to perform, perform, perform. And in my internship, Carla's just like, "What are you doing?" And I'm just like, "Well, I'm just doing what I thought we were taught to do." And she's like, "No, no, you're going way too fast." And eventually, after I got over the frustrations of my people pleaser not people pleasing, I was like, oh, this approach is really cool because I can synthesize this with my massage and then provide lots of space for interoceptive attention.
Yeah. Yeah, so this is, in our trainings, we teach to the research protocol because it's structured, so it's very easy kind of way to kind of introduce some of these, sort of the process that we go to through these fundamental steps, because it's sequenced to kind of help someone learn how to bring attention to the body, and then how to sustain attention in the body, and how to reflect on what they experienced in the body, and all those things. And then the therapist or whoever's taking the training has to kind of translate that to, well, how am I going to bring this into my own practice? Because you don't have to do an 8-week protocol, right? And that's the art of learning anything when you're a body worker or a PT or an occupational therapist or a mental health therapist, is you learn these things, and then how do you integrate them into all the other things that you know how to do. And it doesn't have, it takes a while, right? It just takes a while to find your way. So, but anyway, yeah, I want to just share before we end, anybody who would like to, we have the center, this nonprofit center, we have a website, and I'm just, invite you to look at it if you want to learn more about this work. And there's information of, what is it? When are the next trainings? There's a page that's all about the research and links to articles if you're interested. There's a page with resources, with podcasts, and so on and so forth. So I'm going to put that in the chat just in case that's of interest for anyone to follow up on.
I have one question.
Wow.
For people for whom going into the body is too much, or unsafe, or too much pain, or whatever resistance there might be to focus inward, how do you approach someone who's the idea of feeling their body is just too much?
I've had a lot of experience of that, working with people with extensive trauma histories. So we slow it way down. We're always trying to match the client and where they're at. So one can work seated instead of on a table. One can work with self-touch and instead of having someone touch them. One can work with props so that there's even more of a distance from touch. One can really focus on learning where someone does have ease with paying attention and staying in that realm before moving into areas that are more challenging for them. So really we work on understanding the client well enough that we're constantly assessing what will work for that person, and never going into realms that are going to be re-traumatizing or have any dissociative kind of response associated with them, which is really a key thing to know how to assess that. But yeah, we're not about fixing anything. We're about following the lead of the client and what they will benefit from learning and the pace that they can learn. So I think with any of these kinds of interventions that have been developed where they're for research, they have to be able to be individualized for the person. And that's something that I think a lot of people don't understand. They think, oh, there's a protocol, you have to follow the protocol, right? And there are ways to develop a protocol so that it's designed to be flexible, so that you can individualize it to do just this level of trauma-informed care. And this intervention is. So I hope that answers your question, but yeah.
I have
I
a
would
question,
also,
please. Sorry,
oh,
Marcus.
go ahead.
I have a question, please. Is this only used with trauma patients or clients?
Oh, no. That's just how I no, I developed it from working with that population, but no, not at all. Kind of
I'm
any.
wondering on a very, I'm wondering on a very fundamental or basic level, would it work with a client who, the stereotypical client who fights you on the table? You know, the person that comes in wanting treatment, but their body is not allowing it. You know, you go to lift their leg, they lift it for you, doing the work. I had one client, I stood there and I said, I want you to see what's happening. These are my words to my client. And she was moving her body,
Mhm.
okay, in the massage. So in effect, she was doing the massage and I was standing there and I said, okay, I guess I'm going to make a free paycheck today, you know? And we laughed about it, but the seriousness of it is that she she was not aware of it at all.
Mhm.
Okay. And so I'm wondering if she can be taught
To
how
be,
to feel
yeah.
what's happening in her body and hence, control it, if you will. I don't know if it's just a power deal. Some people are control freaks. That's the way it is. We work around that. I don't know. Maybe is it something that a person like that can be taught and then they can enjoy the massage much better?
I mean, I would say yes, but I qualified with the fact that there's a certain readiness that's
Mm,
needed for people to kind of engage in this type of work. And my experience has been both, in private practice for a long time and then watching, and both teaching and sort of supervising a lot of therapists working in research with people for whom this work is really unfamiliar, is that if things are slowed down enough, that yes, the answer is yes, but there's always the occasional person who doesn't, folks who come into private practice or folks who sign up for a research project like this, they're choosing it, right? Because somehow they're
mhm,
comfortable with the idea or they think it's going to be helpful to them, right? But there's always that person who really didn't understand what it is you're going to be doing, for whom they're really not quite ready, or they don't really want to be there 100%, right? Well, not even
mhm,
100%, even 50%. And they're there because they think they should be or something, right? So there's always the occasional person that's not a good match or it's not the right time. So there's that possibility, right? But I think from the perspective of just trying to, is there something in this intervention that would help one have some more tools to kind of slow way down and
mhm,
sort of think creatively about how to work with a client like that? I think the answer is yes.
okay.
Yeah.
All right. Thank you.
Yeah. What were
Had a
you saying?
client that was, I'm sorry, was there a question?
Yeah.
Okay. Um, a client with dissociative identity disorder who wanted to try MABT, and this was in my internship in graduate school, and we started with it, and he was just like, no, I can't do it. I can't do it. And so then I was like, well, should we try a different spot? And he said yes. And so tried another spot. Nope, I can't do it. I can't do it. And so we went, so I had the luxury of having a talk therapy office and a body work office. And so we went back to the talk therapy office to talk about it. And the next week he came back and he said, I had a meeting, the council had a meeting, which is a group of parts inside of the system. And we believe in the MABT, but we have to do it a little differently. And so we engaged in this proximity building exercise where he would go into the body work room and I would stay in the talk room, and he would walk around the room looking at things, studying the lighting, and noticing his nervous system. And it took him about 15 minutes. And he came back and he said, okay, I'm ready for you to come in to the room. And he had set up some of the lights in a different way and turned some lights off. And he said, I want you to sit right over there next to the desk. And so that was the beginning of our MABT proximity building exercise. It took about 8 to 10 weeks. And eventually he was, he said, okay, I'm comfortable enough now to have you, I'll be on the table and I want you to be sitting on the stool where you would be performing the touch work and talk with me so I know where you're at. And that was how we began with MABT series to get to the point where we could start doing MABT sequencing.
Did you keep working with him?
Yeah.
Yeah, very cool. Nice.
Yeah.
Nice, so nice. Yeah.
And he's a non-amnesic DID client, so he's got access to all of the alters. There would be probably a different protocol to develop for an amnesic DID client, just because of the nature of the dissociation. But I personally think one of the strengths of this work, as you had indicated earlier, is a lot of the clients that you've already researched with have come from pretty hard lives and already have a lot of dissociation in their system. And yet still after an 8-week protocol, they have homework that they adhere to for up to a year, as the research has indicated. And I think about this in the context of, I know we're getting to the end of our hour, but thinking about this in the context of outpatient care for cancer patients and vicarious trauma with family members and caregivers, we can engage in this kind of work and we can facilitate these sessions for these clients and patients and then send them home with homework to adhere to, grounding and regulating into the mindfulness and felt sensations of the homework. You know, if it's something that's already been supported in one demographic, I'm confident that it will be useful for cancer patients and caregivers who are experiencing vicarious trauma. Well, thank you all so much for joining us today. I really appreciate your time. And Cynthia, thank you for joining us and sharing your story and what you're doing and the great work of MABT.
Pleasure to be here. Thank you all for being here. Nice to meet you. Yeah.
Thank you.
Cynthia. Thanks, Marcus.
Pleasure.
Thanks.
Okay. All right. Well, thank you again. And I look forward to future events, the regional champion events. I want to start reaching out and having brief meetings with everybody and maybe have you on as a guest to share your story and to celebrate what you do, and also to remind people that this work is, you know, it's a calling for a lot of us, and it's important to show people what each individual is doing.
Okay.
Sounds
All
good.
right.
Thank you. Thank you all for your time. It's nice to learn with you again and be here.
Thank you. And
I love you,
absolutely.
Amma.
Who said that? I love you too.
Well, have a wonderful evening,
All
afternoon,
right.
wherever you are.
See you next month.
Good
Yep.
night.
Good night.
Night.